Welcome to the Genesis Healthcare Podcast, where we go beyond the traditional office visit to explore what it truly means to live with optimal health. Each episode brings you candid conversations with our Genesis providers and featured guests from across the health and wellness space, covering everything from primary care and prevention to aesthetics and lifestyle optimization. Whether you're ready to take control of your health through a Genesis membership or explore treatment options to look and feel your best, we're here to guide you every step of the way. Ready to begin your journey to better? Visit thegenesisdifference.com to schedule your first appointment or aesthetic consult today.
First of all, I want to say thank you for coming.
I appreciate the opportunity to be here.
Introduce Dr. Dan O'Rourke.
Yep.
He's with Trinity Heart and Vascular here in Johnson City, and has been a friend of mine for a number of years, especially through the COVID years, and is really he's gone from a Western medicine insurance model. You know, we were all trained the same way. Yeah. You went a cardiology route, and so you have always been a fantastic cardiologist and well respected. And I'd love to get a little bit of your story on the model and why you've changed, and a little bit of how you care for patients now versus then, kind of all of that. Yeah. And first of all, just introduce yourself.
Okay.
So, well, and give us a plug for Trinity.
Yeah.
Are we still in Greenville?
We still have an office in Greenville too. Yeah. So as Joe said, I'm Dr. Dan O'Rourke, and I am the owner and founder of Trinity Heart and Vascular Group. We've been in business since August of 2022. And I have wanted to do a direct pay cardiology since 2012, but it was right. It was wise not to do it at that time because the landscape was totally different. But I had seen the writing on the wall many years ago. Mm-hmm. And at that time, my thinking wasn't as clear as it is now, and I hadn't clarified all the issues. But you could see even then that, the insurance model was gradually going to fail. And, our group, in 2010, we had been bought out by a local, healthcare entity. And, that's always the beginning of the end when that happens. You get the bureaucratic layers in there. And then, of course, you get these outside treatment paradigms and all those issues. But the biggest thing from a practical level was in that model is, over the course of my career, the patients have become much more complex. And we were being asked to see 2 to 4 patients an hour. And, if it's a bronchitis or, impacted cerumen, you can do that, right. But, we're talking, heart failure patients, artificial valve, a defibrillator, and you can do it, but you can't do it well. And sure. That's what we want to do. We want to do good medicine. So that was a lot of the motivation for me. And then back, I finished my days down at the hospital in Greenville. I was grateful for the opportunity to go there because they allowed me to go there and not take night call on weekends. So that was okay, right?
So you're like a dermatologist.
Yes,
oh,
yeah.
Good.
So I was happy with that. But then, at that time too, when we left, that was still in the COVID years, and there was a lot of pressures there, and just a lot of things that I didn't agree with the protocols and so forth. And so the decision was made to try, give this a try. Okay. And so, just to give you the Cliff Notes version, I was very blessed because I had a good career, had a lot of capital, so I wasn't really worried if I failed. It was like, oh well, But basically, as you can guess,
that wasn't the case with me.
Yeah. when you especially in a specialty, when you go and say I'm not going to take payments from insurance companies, people think you have 4 or 5 eyeballs in your head, know. And there were people who did respect me. And they were quiet about it and respectful, but behind the scenes, they says, I don't think he's going to make it, Sure. Well, here we are, and as I tell my staff, we ain't bankrupt yet, And but it's a blessing because just the nature of how this was going to play out, it's really not rocket science. Once you get over the initial barriers in your thinking and you see what's going on, it's a doomed model.
Right.
And so you made that choice, and many others are making that choice, and now here we are in early 2026, and direct pay is not a foreign concept anymore. It was 3 or 4 years ago.
And I love this. I love the fact that we have multiple people out there doing this.
Yep.
So I really think, I want to back up just one second and say, we get to worship together too.
Yeah.
Right. You go to Westminster and Kingsport.
Right.
I go to Westminster and Johnson City.
Yeah.
And we have a once a year Reformation Sunday, and you and I get to worship together. So you and I think a lot theologically.
Yes.
Alike. So we align pretty well there. And I think that has a lot of it is the bearing of why we chose to do this.
Yes, it
because
is.
we're here to serve.
Yes.
Serve our God and serve our man. First, but the number one commandment, and number two.
You bet.
Right. And so I think that has a lot of reason why, I've heard, the word burnout in medicine, and I don't think we are designed to burn out.
No.
But moral injury and the morality that we have to do this, basically it's creating us to be liars and cheaters.
Yeah.
And not really pay attention to the patient, pay attention to the algorithm of how to get paid. And so that, I think, has been the real underlying of why we really want to do this.
Right.
And I just want to put that out there. And I think because we align so well theologically, I think that's also the driving force of why we're so easily going, well, the Lord's going to take care of us no matter what.
Yeah.
Right. And life is short. We'll be dead soon.
Yes.
Right. So win-win.
Go for it. And that's reflected. The names of our practices are not just trivial.
Right.
Genesis and Trinity, they're nice sounding names, but they are theologically based.
Right.
And Genesis, beginnings, Trinity,
absolutely,
that type of thing. So, a lot of, there's a lot of, businesses that call themselves Trinity,
right?
But some of them are like us; they mean it. But others, it's just a nice name, that type of thing. But I agree with you completely, and I think that's a big driving force, is because the paradigms in medicine, if I can say it, transgenderism and all that stuff, that's grossly immoral. We're not helping those people who are suffering from that, but lots of money is made to mutilate them,
right?
That type of thing. So, those are things that Christians just have to stand up against in our field, and provide compassionate care. But I'm with you on that. Yeah.
Yeah. And so a lot of the care that we've tried to give people over the years, like you said, has been condensed into, sometimes it's I think the average is like around 7 minutes.
Oh my.
Of a true office visit, and a lot of that's paying attention to a computer screen.
Yes.
And so I was always on paper out here.
Yes.
Until I actually went to the direct model, and now I'm on a computer.
Yeah.
And so what's really cool is I still am on paper, and I write it down and then say, here, go plug this in.
Yeah.
And so it's really nice because I don't have to check a bunch of boxes.
Right.
I think that I really want you to kind of dive into that a little bit, as far as like how you were able to do that from a cardiology standpoint, and give better care. Yeah. Because of the direct pay model.
Yeah. Even when I was in the other system, I felt burdened because I wanted to do a good job.
Right.
So probably about 10 years ago, I started, and I still do it. I call it chart prep. Like I said earlier, cardiac patients are very complex nowadays. Yeah. One of the blessings of being able to access the local health systems and so forth is you can get records, because our patients are great folks, but they're lay people. Yeah, I had one of them heart casts, but they don't really know what the details are.
Right.
So I can get all those records. That was a real burden, but it actually was a means of survival. Yes, there was a lot of outside homework in the other model, but it's the only way I could provide good care. Because, like I said, you try to see these 3 patients an hour. If you don't have chart prep, you're just winging it,
Right.
So that was really good. And then to follow up on your point about the record, it's very important to point out that the modern medical record has become a billing document and not a medical document. Oh, there's medical details in there, but like you said, it's all focused towards getting reimbursement. Where the notes, you've seen my notes from Trinity, they are pure medical documents. I humbly submit they're readable. There's no clutter in there. All right. There's just, here's what we need. And I realize, and another thing I did just to try to help the primary care docs is I put the impression and plan up at the top.
So important.
Because really, you're a busy guy. You're a busy guy. If you want the details, you can go get them. But those details are really for me in future visits. But I wanted to have it that if I'm able to bring on other associates, you want to have a document that is self-supporting. If you just get the last note, it just tells you a good summary and you pretty much know what's going on with the patient.
Right.
So, but that's really important. So when I came forward into the practice, now the real blessing is I'm still chart prep and still very detail oriented. But, I had 2 new ones in the office today, and each patient had an hour visit. That you offer an hour. And a lot of, my feelings on preventative care. And, I'm still very traditional, but I hold an alternative view on the cholesterol hypothesis, as you know.
Yes.
But I can educate patients on this and give my evidence. You heard the lecture. I gave evidence, and then people can decide. But I can tell you people are seeking that out. And It's not even just that particular topic. People, they want to know that their medical provider has the right to look at the data and then make their own interpretation. Mm-hmm. And
give them truth.
And give them truth, right? And the way the humans are, just by our nature, we don't agree on very much. But whenever you have all this mass agreement going on, that's tell you there's something wrong here, right?
I love that.
Yeah. So I hope that answers your question. But that's really how it's working. With the charting and recognizing that it's a medical document, and just the freedom to give the patients the time they need. So we do an hour for a new patient. Our routine follow up is 30 minutes, but we build a little buffer in between, just so if you go over a little bit, because I am sensitive. Patients' time is valuable.
Right.
And even in the model I was in for decades, I really wanted to stay on time as much as I could because I respected the patient's time. And so that's worked very well. And then if it's a complex visit, it's 45 minutes.
Yeah.
And patients who are coming in for a post-hospitalization visit, well, I got to go in the chart and read all that. And some of these people were very sick and lots went on. And so I get that and update their note and summarize what's new, so.
Are you happier?
Oh, my professional satisfaction is through the roof. Yeah.
That's really important for all our providers that listen to this.
It is. It's through the roof. I just feel unshackled because, doing what you do, you don't necessarily have to opt out of Medicare because a subscription fee is not a covered service.
Right.
But what I'm doing, because, a subscription model, certain patients could possibly benefit from that, but basically I have to do a fee schedule, right? So basically when you opt out, I'm free from 140,000 pages, whatever it is these days, of Medicare regulations, which nobody can know what they are.
No, you can't.
Yeah, you just don't know.
I mean, the sky is blue and it's gray and it's orange.
Right.
So we don't know what it's going to do with a Medicare. So yes, we were able to opt out as well. And so,
okay, so you did choose to do that. Good.
Yes,
good.
We did that first thing.
Yeah.
And so I had a TBI agent actually recommend me do that.
Yeah.
So we definitely did that. We've opted out of all of those. And literally, I have been morally encouraged by being able to do what I've been called to do.
Right.
And gifted to do.
Yeah.
And I don't take that lightly.
Right.
And so those are things that, because of our morality and what we try to do to serve, it's been so much more rewarding for me in my 50s now, after 25 plus 26 years of practice. I'm enjoying the practice of medicine and putting the puzzle pieces together, and sometimes inflicting a little pain, and doing some things that are uncomfortable, but actually mean something to someone. And so I'm where I saw a lot of people get frustrated and still do in medicine, I am encouraged to wake up and come to work.
Right.
I mean, I love
Right.
seeing success.
Yep.
And people who are struggling, and we can walk them through that.
Yeah.
And so it's just so encouraging. It's encouraging to see my staff happy and smiling and laughing. And I'll come in and just pop down in the lobby.
So they're not sad about giving up prior authorization?
Well, we still have to do a little bit of that.
Okay.
So fortunately, most of our patients still have health insurance.
Yeah.
But they know that they're not assured of anything with health insurance. So they come and get assurance from us.
Yes.
So our girls and our staff in general, they're just happy to be here.
Yeah.
And I walk in, and literally this morning I plopped on the couch first thing in the lobby and just started talking to I had a patient in there, and I'm sitting in the lobby with them, and my staff sitting there giggling with us, and we're having a big time, and it really is more of a kind of a team approach, a family approach. When you're a patient with us, it's been just kind of like, hey, I'm gonna shoot you this text real quick. Or, hey, can I get in there tomorrow? Absolutely. Yeah. Somebody will see you. So that's been very encouraging to me.
Yeah.
With this transition. With this transition has been patient satisfaction,
right,
and staff satisfaction. And the providers are just tickled to death.
Yeah.
We do work 24/7.
Yeah.
Or we're able to work 24/7, but it's, our patients are pretty respectful of that.
Yeah.
And very respectful of that. And they're like, "Oh, I'm so sorry to bother you."
Yeah.
But I'm like, this is what we do.
Yeah. Yeah.
So,
and that seems to be a common theme: the collegiality, the staff happiness, the family environment. And that I'm hearing that a lot from direct pay practices, because the pressures of an insurance model, they're high. They're very, very high, and so I'm glad we have moved on from that.
I know. So, with Trinity, what all services do you provide?
Right now, I'm the sole provider at this point, working hard to, we're really growing fast. And so I know I have to go through some tougher times to get through that, to be able to bring other providers on. But right now, we're just doing outpatient medicine. I do have ideas in the future. It wouldn't be me, because I'm beyond going back into the hospital, but there is a role for direct play in the hospital environment too, and it's very neat and clean for the patients, at least from a consultant side. It's published. Here's what our consulting fees are. Here's what our rounding fees are, and those types of things. So we would hope to grow into that. But right now we're offering consultations, second opinions, chronic disease management for cardiovascular disease, and we do most of the basic, typically performed outpatient cardiovascular procedures. We do treadmill testing. We do a lot of stress echo. When we first opened, we still could do it. We contracted with a mobile service for nuclear, but admittedly, even in the direct pay model, that's a very expensive technology. Right. And so I can do a comprehensive treadmill stress echo for $350 versus $800 or $900 for a nuclear stress test. So we don't do them anymore, but that was driven by the patients, right, the demand. And I hold multiple certifications. I'm certified in echocardiography and nuclear cardiology, and both great technologies, but there is a significant false positive rate with nuclear imaging, and with echo, the sensitivity may not be quite as good, but you don't get as many false positives. But so we're doing those types of things, ABIs, carotids, just the basic bread and butter things. We have some good relationships where we have maybe 10 to 15 pacemaker patients. So right now it's not even nearly cost effective, because unfortunately, because of the different vendors, right, to try to get analyzers in for each vendor, it's just too much of a hassle. But we've worked out arrangements where our patients can still get their devices checked and that type of thing. So it's worked out well.
What about if you have a positive? where do you go after a positive?
Okay. So basically, if I think the patient needs a cardiac cath, we respect what the patient wants to do.
Okay.
But I do have, respected colleagues from my prior practice who I've known and worked with for years. And I like to, and almost everybody says, okay, that's what you want to do. So that's worked out very, very well. So we have it pretty well streamlined. And I'm grateful to my prior colleagues, because even though I'm not formally a member of the group, they still act as if I am. And I'm honored by that, because it would have been real easy to say, well, you're not in the group anymore. You think they need a cath. Well, we need to see them in consult first, and they don't do that, and that's the proper thing.
Sorry, we had a little hard cut right there. I had an emergency with a patient. So this is direct primary care, right?
Right.
So I was just talking to them about, I went by, I got a phone call last night and went by this lady's house, and she had just been in surgery last week, and so I went by her house today or last night, and just to make sure that she didn't have a DVT. So she had a positive Homan sign last night, point tenderness in the gastroc, and I was like, we might want to get an ultrasound. So I called her this morning. I called and got the ultrasound set up quickly, and now she's going to the hospital with a DVT. So,
yeah.
Fortunately, because I was able to get her address last night, plugged it into my Waze after a livestock dinner, I was able to go over there and do that. So I think those things also free us up from what we were talking about earlier. They free us up to be part of their lives. And part of their families. And because I knew her history, because of, texting and praying with her over her, her surgery, her lumbar surgery that she had, when she called, I knew her history and I knew what was going on. And fortunately I was able, I was still in the car, so it made it really easy for me to do a house call. So 9:45 last night, I get home from her house call, and I'm like, it just doesn't sit with me. So that would have delayed care a few days. This is all the way up to saphenous vein, and so it's a good one. So it's a good one enough for us to say, we got to go to the hospital. Right. So that's also given me a lot of fun. It's a lot of fun to be a healthcare provider. It's almost like you put you take your cape out of your briefcase sometimes, and I get to go in charge. And so that does make that fun. When they do call, it's like, okay, let's go save the day. Instead of let's go be dictated to all day. Right. So you had a story that you were going to
just as an aside to that too, before I get back to the treadmill situation, we've had a couple of patients who they were fairly stable, but they were significantly volume overloaded with heart failure. And we were able to successfully treat them as outpatients. And because, as you know, patients are not thrilled with going to the hospital these days. They don't want to go and try to avoid it. And obviously you got to do what's best for the patient. But we had one older gentleman, he had 2 hospitalizations because of hip surgery complications, and developed some heart failure and about 30 pounds of volume overload. And I said, normally we would want to put you in for IV diuretics. And he said, Doc, I've just been in the hospital twice. I said, well, let's try. Well, we tried, and now he's down 30 pounds, and labs are pretty good, buns up a little bit, but, we managed to do that. So that's one advantage. What we can do is we can, at least in some cases, avoid a hospitalization, which helps the system quite a bit. But the other case I was saying is we had it was about a month ago, we had 2 patients back to back for stress echo, and both of them flunked, and we got them set up for heart cath very quickly. One patient ended up having a stent to the LAD, and the other patient ended up with a 5-vessel bypass operation. But they're both doing great. Symptoms are resolved, feeling pretty good. So, these things happen even in the other model, of course. But part of the issue is patients having trouble getting appointments. That's the real problem. So it's putting a large burden on the ER. So your patient absolutely has to go. But then there's other people going there because of bronchitis or a little bit of that, and it's really making it difficult to get triaged.
And I think that going back to the C word, the COVID word, has really shown us that that we can do a lot of things outpatient.
Oh, absolutely. Yeah.
Because we had to.
We had to. Right.
And there was too much burden on the hospital system.
Yeah.
And people were scared to death to go. And those guys were busting their tails trying to help people, in the hospital as providers and nursing. And so they were just bombarded, and it hasn't slowed down in the emergency departments.
Right.
And so we've kind of created a pretty big snafu in our hospital systems. And I think by doing a direct care model or private pay model, it allows people to get more access outpatiently and for us to be there when needed.
Right.
And so I think that's been super helpful. Today was my day off, and I was fortunate enough to get a lot of things done this morning early at the farm, and then did a few injections with people that were called and said, I got a shoulder issue.
Yeah.
And, so it was kind of nice to be like, all right, well, I want to start off with a podcast this afternoon, and so just come on in about 11 o'clock.
Yeah.
But I noticed that I was able to do that a lot with COVID.
Yeah.
I'd be working on a Saturday morning, working with cows or on the farm, and then people would start texting me, "Hey, I got COVID. What do I do?" And I'd just say, "Meet me at my office at 4 o'clock." Well, it was 9 o'clock in the morning.
Yeah.
And then it was, "Hey, I got COVID. Meet me at 3:45." And so I worked my day up to where I left the farm. Sometimes even took a shower and came over and started my COVID day.
Yeah.
And so that actually taught me how to do a private pay direct pay model, because I was like, I can see patients, when I did. It was the first time I went overseas. A year ago. I was in Scotland and got my computer out and answering emails and texts.
Yeah.
It's really weird to get a text at 3 o'clock in the morning.
Yeah.
But it was really nice to be able to take care of patients, anywhere in the world now.
Yeah.
And I don't have to justify a claim to an insurance company and actually lay hands on them.
Right.
We've co-opted together, and it's been a fantastic co-op because they know that I'm paying attention to their care.
Yeah. Yeah.
And I know that's the same way with you too.
Yeah.
With your pre-chart workups and everything else.
And then of course those things just carry on. You have that continuity, and then the subsequent visits are easier because you already know the patient.
Sure.
Yeah, so that's a very, very big plus. But yeah, this is such an important paradigm, and it has implications. And really, we're not really doing anything new. We're just going, like as Scripture talks about, the old paths. Different subject, but we're going back to the old paths, because when we were kids, Mom took us to the doctor. There was no insurance claim. No. When I was about 11, I fell, and Dad looked at my arm. He said, "Well, it doesn't look broken, but we probably ought to get it checked out." And we did, and we went to the orthopedist, got the appointment the same day. Very, very popular, well-respected orthopedist. It was him and his nurse. This is in the early 70s now. Yeah. And so he x-rayed it, said, "Yeah, it's hairline. It's not displaced, but you're 11 years old. You won't sit still, so I'm going to cast it to keep it from becoming displaced." So he put the cast on. There was no such thing as a casting tech back then.
Right.
And of course, what's funny, he had a cigarette hanging out of his mouth the whole time. It was 1972, right? Sure. So he's smoking while he's casting my arm, and so you come back in 4 weeks, we'll re-X-ray. If it's good, we'll take it off. All of that was $150.
Right.
Now in the 70s, that wasn't chump change.
Right.
But there was no insurance claim. It was affordable. Yeah. And culturally, too, those were the days when, a lot of the people of that generation, they had a very proper idea. I need a rainy day fund. Sure. You need to do that. And that's how my parents were raised, and it worked out well. But we had insurance, but they talked about it as major medical or hospitalization.
Which is what we need to be talking about more and more.
That's what we need. That's really what it's for. We want to make it clear to our audience, we're not opposed to insurance, but we are opposed to the bastardization of insurance.
Absolutely.
And when they went to first dollar coverage back in the 90s, that was the beginning of the end, right?
And it's proven that healthcare costs have just gone up.
Skyrocketed.
It costs more for the patient, and the providers don't get paid as much. And so satisfaction all the way around.
We've been very blessed, and we probably have enough vehicles. But if you heard that one of the dealers in town was giving away a free whatever, you might go down, right? You don't need it, but you'll go. Well, you offer something that's perceived as free, you drive up demand,
right?
And you drive up demand, and then the supply is somewhat static or fixed, then you have a problem. It's just basic economics.
It is, and yeah, that was always extremely frustrating for me when I was working in the emergency department, and we'd have people coming in for bronchitis or an upper respiratory infection of whatever at 10 o'clock at night with 3 or 4 kids.
Yeah.
And I'm thinking, these kids need to be in bed. And I'm like, why didn't you see your primary care? And they're like, we couldn't get an appointment for 2 weeks, for something. And I was like, so there was a strain, and I think that's been super beneficial, from what we can do for people. But the financial strain on the industry has been horrid.
Right.
I think.
Right.
From an insurance standpoint, we were talking about, when we were kids, and the old ways of things. I remember Dr. Harvey over in Irwin. He was a good friend of mine's grandfather, and so people would ask me, they would say, "Do you know Dr. Harvey? You act a lot like him." And Dr. Harvey would have a cigarette. He basically light one off the end of the other one, but he'd say, "Just get a shot of penicillin. Give him a shot of penicillin. That'll be $2."
Yeah.
But and he made a good living.
Yes.
He took care of his family.
Yeah.
And he took care of the community.
Right.
And started Irwin Hospital.
Yeah.
Helped start Irwin
Right.
Hospital. So, those are just things that, you look at the cost of, say, an echo through insurance or another healthcare system, and what it actually costs out of pocket,
right,
and what you can do it for.
Yeah.
It doesn't make a whole lot of sense to charge that to your insurance company.
Yeah.
And so I think that's something that people really don't understand. Insurance should not have to pay for everything we do.
Right.
It should pay for I use the analogy of insurance is there when you turn right in a left-handed turn.
Right.
You hit the guardrail. Yeah. That's when you turn in the insurance. You rotate your tires and change your oil.
Yes.
You pay for it.
You pay for it.
Right. When you turn right on a left-handed turn, you get the guardrail. That's where the insurance comes in.
That's correct. Yeah.
From the financial standpoint, I was in Washington, D.C. at a funeral at Arlington the day that Obamacare was passed.
Okay.
And I sat there and my jaw dropped. And I was just thinking, my healthcare premiums at that time were around $444, $50. So let's just say $450 for a family of 5, for 3 children and my wife and I. And the next year it went to $800, and then the next year it was $1,200, and the next year it was $2,000 plus for the same coverage. And I watched that, and my health care did not improve.
Right.
But my health premiums, my health care premiums, or my insurance premiums went up dramatically because they basically passed a law to mandate that you buy their product.
Right.
And so just like your analogy with the car, if they mandate you to buy a GM car, GM cars are going to get expensive.
Yes.
And Ford cars are going to get real cheap.
Yeah.
So I think that's something that people don't really realize is how much health insurance premiums have and we're brainwashed to think that health insurance gives us care. I use that analogy of insurance being our soft, fluffy bunny that just kind of sits there. Well, this soft, fluffy bunny is just extorting you.
Yeah.
Right. Much like a bunny rabbit would.
Right. Just think your finger's the carrot.
That's right. That's right. And so, I've looked at that and watched that personally and professionally and thought, my goodness, I mean, like, we have not improved anything and maybe gotten worse in our care because we're so busy. We can't get off the hamster wheel to look from side to side. Right. We have to go, I got to keep spinning.
Right.
Because if I look to the left or look to the right, which you and I have done, is get off the hamster wheel and go, there's something different we can do.
Yeah.
So are there any other things that you want to talk about from your practice standpoint and things that you would like to, encourage people to understand from what the cost benefit from cardiology and how that benefits the patients?
Yeah, that's a great question. I appreciate it. In one sense, one of the greatest benefits is access. And as you know from doing direct pay for a little while now, when people have skin in the game, they tend to be more compliant patients, and people realize, I think I have a problem here, so I want to get it taken care of. So we're grateful that we have the ability to see patients fairly quickly. So that's a big plus.
Right.
But the other thing too is that people, it's not a massive number of Medicare patients, but we have more than I expected. And, of course, we're very familiar, but just for the audience, there's basically two types. There's original Medicare, and then there's the Medicare Advantage plans.
Right.
The original Medicare, it's a little more costly for the patient, but at least, there's a little prior authorization pilot project going on now with original Medicare, so the camel's nose is now under the tent. But, when you look at, every fall we all get sick of seeing those, Advantage plan commercials every year. We see those. But, whenever they're offering you a zero premium, you really need to say there's got to be some strings attached, and there are, and that is in the form of out-of-pocket costs. So for those patients who have Advantage plans, we've had a number of them. They came in, they wanted to see me because they knew they could get in quickly. And they said, well, I need an echo. I appreciate that. I'll use my insurance. And I said, let me advise you one thing. Happy to help you with that. We'll give you the requisition. But before you do that, call your carrier and just see, what are your out-of-pocket costs and so forth. And large numbers of these people call back an hour and schedule with us because the cost is either the same or it's actually less than what their copay is. So, when you have a zero premium Advantage plan, if you go into the hospital with a significant illness, you could pay thousands of dollars. Now that doesn't happen once the Part B deductibles met in original Medicare. You don't have that problem.
Right.
But again, those patients, the ones that come to practices like ours, they know. One guy said to me, I have this card, but if I can't see anybody, what good is it? Right. The card itself provides me no medical care.
There's no care in a card.
It might pay for some care, but without the care, it does me no good. And that's very perceptive. And I think that's what's driving it because I don't know. I don't have my ear to the ground, but I do think probably more and more docs, a lot of them are employed in the local system, but those that aren't, they just holding their panels now. They're not expanding them. As we know, reimbursements are dropping. And so our office costs are not dropping, so that has an impact too. But those are some of the financial things, and then too, many of our patients, they'll try to file a claim. I mean, we're considered out of network. I don't have good statistics on it, but a minority of patients do get something back.
Right.
A handful actually got back more than I charged, by contract, so good for those patients. But again, it's just that when you can offer an hour visit and, long follow-up times and can do the testing, that's really important to people, and they know they're getting value for what they're doing. And we talked about, some of the other aspects, having the time to give care and those types of things. But one of the things that frustrated me, and I admit, my thinking, I've been practicing cardiology since 1989, and my thinking has evolved over the years. As you know, I'm very much into preventative care. That's been much neglected in American medicine. It's talked about, and it's sincere, but lose some weight and do this, but patients aren't told how, what's going on. And then, as you know, where my views really started changing is there are some disadvantages to getting some birthdays under your belt, but other advantages are you've lived through the changes.
Right.
When I was in medical school, DRGs were first coming out, and a lot of those guys were having a fit, and little did they know how the future would turn out. But now we've gotten into this situation, and where there's we've just seen the metabolic health of our country collapse, and now the answer is obvious. It's a highly processed, highly inflammatory diet. Even as you know, the government finally admitted a couple months ago that, you guys were right, the food pyramid was upside down. And there's a physician in England, Malcolm Kendrick. He was an anti-statin crusader from the beginning, but he also was into preventative cardiac care and so forth. But he said the idea that we should not eat saturated fats wasn't just wrong, it was catastrophically wrong. Right. Because, when I was in medical resident, we all had to have big clinics, and we were in big city hospitals, and they were great. You learned a lot, and, you had good guidance, but you took care of the patient. I had one type 2 diabetic. All the rest of my diabetics were type 1s. And people wanted to see the chart because it was like I had a unicorn in the exam room, Well,
that's also when the A1C average was a 7.1.
Yeah. And so
we didn't even diagnose that.
We probably had some.
Hyperinsulinemic.
Right.
Hyperinsulinemia was not even heard of.
But I really do believe that it wasn't present in the 60s because, we went to the beach as kids and everybody was thin, right? So now we've had this massive increase in weight. I went to a lecture in 2011 at Ohio State. Great lecture, a variety of topics.
Other than it was Ohio State.
Yeah, Ohio State, right. But they were talking about obesity rates in Appalachia, and I'm thinking, why are they talking about it? Well, I didn't realize Southern Ohio is considered the northernmost reaches of Appalachia. Yeah. And these guys were way ahead of their time. It was 2011. They hadn't quite figured out the processed food stuff. But they said then, these are mainstream as it gets, right? They said, the food pyramid's upside down. Telling people to eat cereals and breads and all this stuff, where 80% of your calories.
Agriculture.
Yeah. But the problem is that they also had the studies from the 50s that some of them were actually fraudulent that said don't eat saturated fat. Yeah. Well, that didn't leave much choice, right? So you ended up eating polyunsaturated fats and the Crisco oils and all those things. So that's been a big part of my practice is we really focus on inflammation. As you well know, there's a lot of blood testing. You don't have to do a lot, but you can get blood testing to help. Yeah,
just a few markers.
All you need. And
your ears listening to what do they eat?
What do they eat? Exactly.
Give me a food journal.
And so that's really helped us. And again, as a cardiologist, very briefly on the statin issue, I was a critical care cardiologist my entire hospital-based career. I mean, we did outpatient work, but even in the early days, I noticed that there were huge numbers of people who had a significant atherosclerotic burden, and they had perfect cholesterol levels. I mean, perfect. Even by today's stricter standards, they wouldn't be treated. And the opposite was true. We're not talking a few anecdotes. It was a lot of patients, but you're just one guy. But I would say that sometimes, I'd come out, this 50-year-old guy just put 2 stents in him. His cholesterol total on no meds is 105. His LDL on his own is 80. Why does he have this plaque? And then you'd shrug and you'd go on. But you've heard me speak on this topic, but there was a calcium score study from 2003, and it proved the empirical observation they showed that there was no correlation between a calcium score and any particular cholesterol level. It was all over the map. It's a shotgun thing. Yeah. So as we all know, correlation does not necessarily prove causation, but absence of correlation excludes causation. I mean, that's the basis of the alibi.
Absolutely.
Well, Joe, we think you might have killed this guy. Hey, I have 100 people that saw me in Alaska when the guy was murdered, so it's airtight. But that's true, and that's even justice relies on that principle. So basically, the other thing we had talked about very briefly is there's a thing called the LDL paradox, where the data clearly shows that over age 50, as you age and your cholesterol trends up, so does your life expectancy. That's a shocking thing. Now, I'm not going to overstate that. It's not real dramatic, but probably 80 to 90% of our cholesterol is genetically determined. It's manufactured. So the cholesterol level you have is what you're going to have. But we also know that critically ill patients, if they're in the ICU for 3 weeks, we've all seen those patients. A lot of them, they'll drop their cholesterol while they're in the ICU, and as they recover, it goes back to their baseline. Also, patients with terminal cancer, you'll also see their cholesterol levels dropping.
Yeah.
And so there's a clear linkage, at least, I'm not saying it's causative, but there's no doubt if you're dying, your body is not manufacturing a very important substance, So I've had a number of cases now. I never thought I'd live to see myself say this, but I've said to patients, your cholesterol's too low. And
I don't like where mine is.
Yeah.
Mine's low.
Yeah. And if it's on no drugs, well, okay, you're there, that's fine. But, with cardiovascular medicine, and you've seen this, well, we're lowering it, and then they lower it some more. But has it really impacted the incidence of vascular disease? And the answer is no. Still the number one cause of death. And so the benefits of statins have been massively overestimated. And then, too, with the PCSK9 inhibitors, they all work. They lower your cholesterol, but the question is that beneficial? Yeah. And so we educate people, and I get consults every week. I don't really advertise that viewpoint. I guess I am today here, but people have heard through the grapevine because they're very weary of it's not just cholesterol drugs. It's all kinds of medications. You take this, take that. And, people, they respect medicine. They know it can be helpful. But as you know, we overdo it in this country.
Right. Well, and to play on your vascular inflammation statistic, I was reading an article that in the 1970s, basically the only people who had fatty liver disease were alcoholics.
Yes, that's correct.
And now 40% of our adolescents have fatty liver disease, and 60% of our adults.
Right.
And I would say that's even higher now.
Right.
Because that was about a 5-year old article.
Absolutely the case.
And so, fatty liver disease is definitely because of vascular inflammation and insulin resistance, and
metabolic
hypertriglyceridemia.
Metabolic syndrome, all that.
I mean, I feel like I could look at somebody's triglycerides, fasting insulin level, and VLDL and say, all right, I can tell you what's going on.
That's right. That's true.
I mean, really, there's and we have a lipid panel, a basic lipid panel that's a 40% accurate test that we have hung our hats on for the last 30 years.
Right.
And that's what we knew.
Right.
But fortunately, I think, because of your life experience, even which you've talked about, and your work experience, and opening your eyes, it's helped us understand that, and learn.
Yeah.
And I'm okay with being wrong in the past.
Yeah.
And then trying to be right. For you.
Well, we had to explain this explosion in metabolic disease.
Yeah.
There can be a gene defect that develops for whatever reason, but that takes generations, hundreds of years to work through a society. This happened in 40 years, 50 years. Even back when I grew up.
Well, now it's coming down from Washington.
Yeah.
You got RFK Jr. is just saying, hey, we're taking this stuff out.
And a lot of it's policy driven because it's bankrupting us. All this metabolic disease, but the key thing, as we all know in medicine, nothing works for everybody. But a strict low-carb with as much avoidance of processed foods as you can will fix 90% of type 2 diabetes and most fatty liver. Not everybody, but the vast majority. And so,
You know what's even better than that? Fasting.
yes,
You
the
know
intermittent fasting.
You know what fasting comes from? Scripture.
Scripture. Yep. Yep.
Yeah.
Yep. And that is a key piece, because I have a lot of folks at our church that, they're lay people, but they're intelligent and they've read, and they were ahead of the curve on this, because there were other contrarian physicians they would read and so forth. But
Are you calling us contrarian?
I think we are.
Okay. Good. I just wanted to make sure I was in good company.
We should probably get T-shirts.
I'm a contrarian.
Yeah. But we had a fellow that he lost a substantial amount of weight, following a good diet, and he's still pretty good with it. But you get a bunch of grandkids, and there's always birthday parties and stuff, so you enjoy those times. But the fasting piece is important, because really that's how great-great-grandpa ate. Yeah. He didn't have constant access to food. There wasn't as much food preservation, so you had to eat it pretty quick. And then obviously, back, if you come to Washington County in 1900, maybe Johnson City proper, the actual city then, had electricity, maybe. Mm-hmm. But you get out to where we are now, it was all farm country. There was nothing out here.
Yeah, we had black cows out here, and it was really pretty.
Yeah, and guess what? It got dark, you went to bed.
That's right.
You weren't watching Netflix and eating Skittles and Doritos, and I think those things do taste good.
Oh.
To me, they do, but
I miss a Skittle.
They're bad. They're bad for you, right? Right. So, so that to answer your question, that's one of the emphasis of our practice, because we have the time. Yeah. Because I probably spend 30 minutes of a new patient visit just going over the anti-inflammatory lifestyle.
Right.
Which you don't. In fairness to our colleagues, how can they?
They can't.
They can't.
No.
Right.
And that's what I try to defend our peers and our colleagues, because they just don't have the ability.
It's not the individuals, it's the system. It's the
absolutely
the system is, because everything we've talked about so far, it's all interrelated in some way.
Yeah.
Like even from the fallout from the COVID, there were a lot of people that left the hospital system, employees, they never came back. They still haven't come back. And this isn't just here in Tri-Cities. It's all over the country. Staffing levels have not returned to pre-COVID baselines. It was hard. It was a stressful environment. And
PTSD is
people.
Super, I know I have it.
Yeah.
I mean, you start just saying the word COVID around me, I start twitching.
Yeah.
Because it was 7 days a week.
Yeah.
And not just office hours. It was after hours.
Yeah.
It was just. It was heavy, and there was, if you were working in a hospital system and you're having to do this and having to do that, and
then it's a controversial topic, but again, there was data from decades ago. The social distancing measures were never proven to work, but that demoralized a lot of people, and so
I don't think the society has recovered from
no.
Just the saying, you're not allowed to go to church, you're not allowed to touch someone,
right. Right.
I mean, you're not allowed to interact. When's the last time you drove down the road and somebody waved at you?
Yeah.
I mean, everybody's 10 o'clock, 2 o'clock. They don't want to talk to you. Don't want to look at you. You go in the grocery store. You're not, hey, honey, how are you today?
And that wasn't a feature of our culture here.
No.
That's a new thing. Yeah.
Yeah, it is. And I don't think it's just the influx of people that are coming from other parts of the country. I think they come to the like has attracted like, but we don't like each other.
Yeah.
And I think that's really, it's been demoralizing, I think, to us as a society. And, I love to wave at people that running down the road. I mean, if somebody lets me out, I wave.
Yeah,
somebody,
we still do.
I let somebody out, they don't wave, I wave.
Yeah.
I'm like, how about a wave? Right. So, I think I want to bring back the wave. Let's bring back the wave.
Yeah.
Just, hey, how's it going?
How's it going?
Or maybe like a little, hey,
yeah.
Off the steering wheel.
Yeah. Yeah.
But I think social distancing, if you're sick, go get in the furthest darkest corner of your house, sit there until you're better.
Yeah.
And I think we've just created a fear.
Yeah.
And these cell phones haven't improved much either. So anyway, we can go down a lot of rabbit trails on that, but I am really excited for you guys and us as clinicians who have taken this step and done it for our self-interest, and just self-preservation, and the benefit of our communities, and so I don't think that, like we were, the you take care of yourself first so that you can take care of others. So I think this has allowed us to take care of ourselves to the point to where we can breathe a little bit and have a sigh of relief, and when an emergency happens, we can jump up, put our cape on, fly to the emergency, and come back, and then put it back in the briefcase and have a conversation again. And so I do think that I see the joy in your face as a colleague and a mentor to me, that I can go, wow, this is really cool. I think it's something people ask me, they're like, when are you going to slow down and retire? When are you going to retire? I'm like, why would you retire from this? Right.
Yeah.
I mean, I just want to keep doing this, and until I'm gone.
Yeah.
Right.
Yeah.
So,
and I think those of us who sort of were pioneers here, we have to be patient. We didn't get here in a day. We're not going to get out of it in a day. But I really feel, it's sort of a covenantal way of thinking, from our theology. But we want to build for the future because, I'm very healthy and I could live a long time. But same token, my runway is a lot shorter than it used to be, And so, but you want to build that foundation for future generations, because, we have to get back to a more of a cottage industry medical delivery system. And because the current system, it's broken in so many aspects. But, we're doing our thing here, and we've worked hard to try to build a reputation. But in reality, too, that's part of it. But it's just this: people see it's different. My nurse told me a couple weeks ago, and this was one of the best compliments we ever got. And the patient said it in a very complimentary way. She was checking out, and my receptionist came back too, and they said, this lady said, I've never seen a practice like this before, but they meant it in a good way. Our visit, people talking, the staff bantering, just that kind of a thing. And again, that's not a criticism of we were in that system.
Oh, absolutely.
But it's the system. It's not that our colleagues don't want to do that, but they can't.
Right.
You can't do it in that system. But also it's, tying back into Mr. Kennedy's efforts and stuff, like Medicare, Medicaid admin cost $2.6 trillion. Well, if you don't, it's already probably pretty hopeless in that, but still, you have to get a handle on that. And so he recognizes that a lot of this metabolic stuff is very expensive. So, there's so much to be grateful for, and it's exciting. But to any physicians and PAs and NPs that are out there listening, it's a swallow hard decision, but I don't think you'll regret it.
No, and I'll tell you what, people will comment on, oh, well, you've got it made, or well, yeah, I'll show you the playbook. It's not easy.
Right.
As far as when I started 17 years ago and in the insurance model, and it was super tough. I started in January, didn't get an insurance check until October.
Yeah.
You basically cannot open a solo practice.
Oh, it's massively expensive
in the healthcare.
Yeah.
And use healthcare.
Right.
It's just almost impossible.
Yeah.
And we were fortunate to be able to do that, kind of running on fumes, as we both know how to do. So the transition to the direct pay model was even heavier because we were pretty successful when we did that.
Yeah.
And it was, even my bookkeeper, who was my bride, was like, "Are you sure?" And I was like, I've got to keep my heart.
Yeah.
And in order for me to keep my heart, and my daughter and my daughter-in-law are both in medicine, going in medicine. And I was thinking, I want to be able to do this for generations.
Yes.
And, and my staff, I've got great providers here. And so I really wanted to make sure that they had a place that wasn't going to be owned by corporate.
Right.
I'm the corporate here. I'm a dictator.
Right. You're benevolent though. Yeah.
Benevolent dictator. Right. Right. So, but it's kind of nice to be able to do that. And they've got the same kind of heart as I do.
Yeah.
As far as the service part of it. And I just absolutely love watching them work, and smile.
Yeah.
And we're all in one office.
Right.
So all the providers are in one office, and the nursing staff's in one office. So it's like the locker room.
Yeah.
Right. So we all come in there, and we'll circle every once in a while. We'll have a case or just pass that around. But most of the time we're like throwing spitballs at each other.
Yeah.
And, trying to do stuff. But it's actually just it's enjoyable.
Yes. Yes.
And it's not the grind of taking home an hour and a half of paperwork.
Right.
Computer work that night.
Yep.
Which I just couldn't imagine doing.
Yeah. And now that we've been out of it for a while, there's no going back. Yeah.
No, I believe I'd be a pig farmer before I did that.
Like you said at the beginning of our discussion, we have a common goal, and this is where the Lord has put us. At least right now, I'm not a pig farmer, but I could be. Nothing wrong with that.
I like it.
But this is where we are, and so this is what we have to do to serve. So, and I think the future is bright, and not that there won't be bumps in the road, but I think the last few years have been very clarifying, and it has exposed the substantial weaknesses in the American medical system. Yeah.
Well, thank you.
Thank you, Joe. Appreciate it.
It's always a pleasure.
Yes.
Thanks for tuning in to the Genesis Healthcare Podcast, empowering you to live optimally. Ready to take the next step? Visit thegenesisdifference.com today to learn more.